Assistant Professor from SNS College of Physiotherapy. So this video is about a clinical condition called Gullian Barre syndrome. So it is a clinical neurological condition which is a rare condition. So final year student is going to have a group discussion about the introduction of Gullian Barre syndrome, clinical features, pathophysiology, epidemiology, etiology, investigations and management. So starting from Bhavani, she is going to explain about the introduction. Yes, please.
So Gullian Barre syndrome is acute, progressive, rare autoimmune disorder that affects the peripheral nervous system. It is characterized by abnormal immune response against the myelin sheath and axon of the peripheral nerves, which can lead to muscle paralysis, weakness, pain, numbness, tingling, and also lead to loss of sensation. So this is about the intro. So explaining the epidemiology. The epidemiology of Gullian Barre syndrome, the incidence is 1 to 2 cases per million population. So coming to the age distribution, it is common in all age group, but the incidence increases with aging. Also, the prevalence is more in males compared to females.
Now we will come into the etiology part. Etiology of the Gullian Barre syndrome, mainly causes of the Gullian Barre syndromes like bacterial infections, viral infection, protozoal infections, surgeries and blood transfusions. These are there. Like bacterial infections, like particularly mycobacterial bacteria, mostly causes to the Gullian Barre syndrome. It will be affected the myelin to causes the Gullian Barre syndrome. Like viral infection, Campylobacter jejuni virus mostly causes to the Gullian Barre syndromes. Major surgeries and infections to causes the Gullian Barre syndrome. These are the causes of the Gullian Barre syndromes.
Next, classification. GBS has several clinical subtypes. First, acute. Next, classification. GBS has several following subtypes. Acute inflammatory demyelinating polyreticuloneuropathy. Primary demyelination with the secondary axonal damage. Most common in Europe and North America. The most common sign is muscle weakness that starts in the lower part of the body and transmits to the upwards. Next, Miller-Fisher syndrome, which paralysis starts in the eyes with associated with unsteady gait. Next, acute motor axonal neuropathy, pure motor involvement without sensory loss, common in Asia and South America. Acute motor sensory axonal neuropathy, more uniform involving both motor and sensory axons, slower and often incomplete recovery.
Now I am going to explain the pathophysiology. So Gullian Barre syndrome initially starts with any infection in the GI tract. So when there is an infection, the immune system produces antibody against this. So in Gullian Barre syndrome, any infection of GI tract, the microorganism contains amino acid. This mimics with the amino acid in the peripheral nerve, myelin sheath of the peripheral nerve. So the immune system, due to molecular mimicry, attacks the peripheral nerve's myelin sheath and also it attacks the axon. So there is interruption in the nerve signal, interruption in the transmission of signal in the nerves. So it can lead to muscle paralysis and weakness.
Now I am going to explain about the clinical features of the GBS. The onset and progression of the disease is 1 to 3 weeks after the infection and it reaches the peak within the 2 to 4 weeks. Now the motor symptoms. It is symmetrical and ascending muscular weakness. It has the reduced and absence of deep tendon flexus, facial weakness and oculomotor weakness. Now the sensory symptoms. It has the paresthesia and sensory loss is usually milder than the motor. Now the autonomic dysfunction. It has the blood pressure fluctuation, cardiac arrhythmia, urinary retention and incontinence. Now the respiratory involvement. The weakness of the diaphragm and intercostal muscles are there and may require ventilation support for the 20 to 30% of the cases. Thank you.
Coming to diagnosis part, diagnosis criteria can be weakness over 1 or more limbs, areflexia, hyporeflexia, disease course more than 4 weeks. Other investigations which includes CSF analysis where protein content will elevated up to 700 mg by dl, spinal puncture, other blood tests to rule out the other causes, spine enhancement, MRI spine. Differential diagnosis include Parkinson's, myasthenia gravis, botulism, acute myelopathy. Under management, where the primary principles of management includes ventilatory support who has a respiratory muscle paralysis, plasma exchange, plasma plethysys, intravenous immunoglobulin. Physiotherapy management which includes active and passive movement to prevent contractures, gradual mobility training and strengthening exercise. shows immobility, contracture and muscle atrophy, and chronic pain and fatigue.
So we have discussed about Gullian Barre syndrome condition. So in which we saw the clinical features, classifications and everything. So coming to physiotherapy management, so each patient will depict different clinical features. So based on the clinical features, the physiotherapy management should be planned. So the treatment goal should start from short-term goal to long-term goal. So our final destination should be giving back the day-to-day activities near normal to the Gullian Barre syndrome cases. Since it's a rare case, so we can see only few cases in the clinical setup. So we have to follow up the cases according to the clinical features and the severity. Then we can rule out the cause and then we can address the management according to the clinical features. So that's all about